All right, attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse. Welcome to another episode of the Chiropractic Research Breakdown. I'm your host, Dr. Anthony Pellegrino, and I'm here with our guest, Dr. Rob Kessinger. Each week on the show, we break down the most relevant chiropractic science and philosophy necessary to empower you to change the health of your community from the inside out. Before we jump in, if you guys are listening live, we're going to do a little bit of work. If you aren't listening on the audio, I got into the office this morning where we record all the episodes, and it sounds like the construction we're doing next door is full-fledged. So if you guys can hear anything under me right now, we're going to have some tile next door because that's what we're cutting. So if you guys are listening live, I do apologize for that, but you're going to want to listen anyway because Doc is going to bring a ton of value. Dr. Kessinger is huge in the upper cervical community. If you guys go on the Index of Chiropractic Literature, which I highly recommend, and just search his name, you'll see study after study after study after study referencing changes in the autonomic system, changing in the cardiovascular system, how those interplay together. And it's just absolutely, I'm so excited to have him on here to discuss this because this is some really good quality evidence for the changes in function in the nervous system following chiropractic care. So with that, Doc, the study that we're going to start talking about today is recently in the Journal of Clinical, or the JCCA, you published this study on pulse pressure following upper cervical care, which is a practice-based observational study. We mentioned that that's one of the outcome measures that you kind of use in your office for your practice members to actually be able to monitor change. So I'd love to just hear a little bit more about your process, how you did this study, how you collected the data, everything like that.
Okay. All right. Well, first, the pulse pressure. If you look at pulse pressure, I think about 3 or 4 years ago, there was a big meta-analysis study, had about 8,000 people in it. And what they found was if your pulse pressure raises by 10 millimeters mercury, you have a 20% increased risk of heart attack, stroke. Also, they found that if you have a pulse pressure that is elevated, it's actually more of a predictor of heart attack than regular blood pressure alone. So, but anyway, when we looked at this, purely from the standpoint, I actually should define what pulse pressure is. Pulse pressure is basically you take your systolic pressure and you subtract the diastolic pressure. So if you have 120/80, then you would have a 40 pulse pressure. If you have 130/70, you would have a 60 pulse pressure. So 40 is considered normal. Once you get up to 50 millimeters mercury, it's considered elevated. Once you get up to 60, it's really high. Just as a definition of this, basically what happens is that in between your beats of your heart, when your heart does lub dub, and in between that, where it's lub dub and then there's that rest period, you're in what's called diastole. Now, I don't want to bore you with all this. This is going to be really cool in just a second if you can hang in, because this is all about the autonomic nervous system, and this is all about how the upper cervical has a major play into the physiology of not only the brain, but the body itself. Because really the autonomic nervous system is the big, it is the big regulator. It regulates the immune system, the hormone system, even the neurotransmitters. And that's what gives you balance. That's what allows your body to heal itself. That's what allows you to adapt to the environment. All the things that we really would put as a definition of health is your ability to respond to the environment. And your autonomic nervous system is all wrapped up in that. So going back to the pulse pressure, when your heart, which is the ventricle down here, when it pushes the blood out, it has to go past the wall of the aorta. So the aorta it's sitting there in a resting state. And at a resting state, it has enough blood in it that it's exerting 80 millimeters mercury in this example. When your heart beats, it has to get past that. Now, here's what happens, though. Your aorta goes up, and then it splits when it goes to the big arteries. Right at that junction where it splits, where that pressure is going, now you have a pulse wave that comes back toward the heart. So that pulse wave that comes back to the heart has to be overcome with the ventricle pushing through. Does that make sense?
Yeah.
I'm sitting here in my head. I'm listening to myself. I'm thinking, I'm not sure that makes sense.
No,
But
I'm following.
okay, great. I need the feedback. Good. So as the pressure is going down the highway of this big artery, it hits the junctions, like when it's going to the legs, going to the arms, and whatnot. When it hits those junctions, some of that blood certainly is going to the rest of the body, but some of it actually pulse waves back to the heart. Now, if you have a really stiff artery, aorta, then that's going to rebound really fast back to the heart, and that's going to make you have to have a bigger, harder thrust to get blood through, so you have to have a higher pulse pressure. Well, of course, we know atherosclerosis will make those pipes like lead, but that's not even close to the most common reason why you have pulse pressure. The most common reason why you have an elevated pulse pressure is sympathetic dominance. It's just simply that the sympathetic nervous system uses norepinephrine as its neurotransmitter, and when you have a lot of norepinephrine circulating around in that aorta, in those big arteries, it's going to get stiffer, and then that wave is going to come back harder, and you're going to have to push harder against it. So I hope that wasn't too complicated, but when we look at it, your pulse pressure is a really good indicator of autonomic function. And matter of fact, it's a better indicator of autonomic function than blood pressure alone. So when we did the study, we had 5 clinics, and we had 130 subjects. So basically there was an 8-month period of time where these doctors, every new patient that came in that consented and was okay to do the study, they signed a consent form and we did it. And then at the end of the study, we came back and looked at the data to see what it looked like. And we found that we had statistically significant changes in elevated pulse pressure, which is actually a big deal. We also saw changes in blood pressure similar to what Dick Holtz found in his study. Dick Holtz found a drop in systolic pressure of 17 points in his great study. But we didn't want to just repeat that study because that had already been done. We wanted to look at it from kind of a novel approach to see, as I said, we want to see how we can measure what's going on in that autonomic nervous system pre and post, our upper cervical care. That was really kind of the impetus of the study.
That's awesome. And a lot of what you're saying, because it's we mentioned you studied under Dr. Kale.
Yes.
It's knee chest upper cervical that you utilize, right?
Mm-hmm.
And one of the things that we in the show and everything look at is we always try to critically evaluate data, whether or not it supports principled, neurologically based, evidence-based subluxation-based chiropractic or not. And one thing that we've spoken about on here is a study that was done, I think it was Texas Chiropractic or National, that looked at atlas manipulation and showed there was no cardiovascular changes. And all they did was, and I'm not sure if you read this, they said there was no cardiovascular changes. And then you're like, well, that's so different from what we experience clinically. So you want to go look further into it and say, why is that so different from what I see in my practice on a regular basis? And it turns out that their methods were, we hit them on the left, we hit them on the right, and we compared those two different things to a baseline. And of course, if there's no actual evidence of subluxation, right, if you just slap somebody on the side of the neck, you're probably not going to get these kind of changes. So when you look at your evaluation, your outcome measure, your actual evidence of subluxation, clinically, I don't want to go too much into technique. It's a little bit of a different topic. But clinically, what are the indicators that you're looking at to see, does this person need to get adjusted? How do they need to get adjusted, et cetera?
Okay. Let me do this, but if I may, I would say it would be about the boldest, most arrogant statement somebody could make. Just making a plain statement that we studied this and it doesn't do that. That's my boy. I did not see that study, but I can say just at the outface, you can't take one measure and say that you know the physiology of the body. That's like, that's like looking at the Earth, from a 2D picture and say it's a flat Earth. You can't do that. There's too many moving parts. I don't understand. That blows my mind that statement. I haven't seen the study. I have to look at the study, but I would say you just can't do that.
I'll email it over to you after this.
Well, that is not evidence-based. You can't, that's not the way you do that. You can't find a null hypothesis and say, the Earth is flat. You just can't do that. So, okay. And your point's well taken as well, because in the measures that we use two primary measures. We use pattern analysis, and our pattern analysis we do through the Titron. Now, the pattern analysis we do in the KCUCS. KCUCS is the technique that we're part of, and so it stands for knee, chest, upper cervical specific. Now, in the KCUCS work, we use the pattern analysis that was developed by Duff. We've modified it some, but we do the Duff analysis. The Duff analysis is what I would call the premier pattern analysis out there. There's a lot to it. There's a lot of science behind it. And basically the way we run the graph is we run the graph the same distance every time, and we start at the exact same place every time. And that way, when you line up 5 scans, you can see exactly if there's breakpoints in there or not. For those who don't know about breakpoints are those places in the pattern that break that same way every time you see it. When you see that, then that's a repeating pattern, and that gives you an indication, primarily if it's in the upper cervical area, that person, quote unquote, would be said to be in pattern. So we don't adjust people. And to your point here, I think this is a great point. We had 12 visits through all across the board. We had it right at 12 visit average, and we only adjusted 2 times on average. So out of 12 visits, they got between, we had one of our doctors adjusted a little bit more, but 4 of the doctors in the group actually had 2 and less adjustments on most of these people. And I would say that out of the 130 people, there were about 30 to 35 people only had 1 adjustment, and then that was 6 weeks later. So that is like the epitome of subluxation base, what you may call principal chiropractic, in the sense that we don't adjust in our technique just because somebody shows up on Tuesday, right? We adjust in our technique based upon, are they in pattern? Are they holding? Are they not holding? The other thing we also used in our study in our technique is we use leg checks. Now, some upper cervicals use leg checks as their primary assessment tool. We use it as a secondary. Now, there's a lot of benefits to the leg check, and there's a lot of great techniques it uses as a primary. So there's nothing negative about that. It's just the format, really, and how we do that. And so, and I'm sorry to skip around. I do have to say this, though. I had some great investigators with us. Myself, no, I didn't just call myself a great investigator. Let me retract the record. That's not where I was going with that. But we had Trevor Qualls, we had John Hart, we had Andre Dalius, we had Mike Anderson, Leland Bradshaw, and Jared Whalen were all part of this study. And they did just a fantastic job getting it together with us. So.
Yeah, and the reproducibility across 5 clinics is, it is an observational study because there was no control. But the reproducibility across 5 clinics with 130 people, that's great with different clinicians everywhere.
It's stronger. We start off, we have anecdotal evidence, and a lot of people say, well, that's anecdotal, it doesn't mean anything. Well, it does mean a little bit. It doesn't, you can't really go to the bank on it. But if you see several clinics, there's everybody saying, hey, we do this work, and a lot of people we see get better with this or that or the other thing. Well, then we have case studies, right? Somebody, you have one patient that came in, you had this happen, you report on it. That's important. And then you have a case series. One doctor reports a number of cases, and you're exactly right. Really kind of the ramped up of that is to do a case series with multiple clinics. And really and I may get into that later on, but I'm not, my purpose and my mission at this time has not really been to do the RCTs and those other things. I may do that, but really what I want to do is just help kind of put a stake on other chiropractors who, have a passion for this, can build on the work that's been done, not only from me, but from all these other great doctors who've put things out there, So it's all about, building blocks so that we can reach into the future.
I completely agree. And I think that's one thing that we get a lot of flack on is like, oh, it's just case study after case study after case study after case study. And those case studies are important because there's no point in doing the work that you did, right? Like there had to be something that said, hey, I observed that this is true first.
Yeah, you have to have published on. To stand on. You have to have shoulders to stand on. Absolutely.
Absolutely. And then
Good.
even in those case studies, we proposed hypothesis as to why would this change.
Right.
And then the further evidence was to take that and say, hey, what can we do to be better? What can we do to make this more reproducible?
Yes.
And I love the fact that we have somebody like you who's actually doing that, right? And is actually doing these types of studies and doing this work. And yes, like you're in practice. So
right.
the ability to go, like, RCTs are work. I'm
Yeah.
personally not doing them. I'm not even, I publish a case study every once in a while personally, but all I do is talk about other people's stuff. Like,
Right.
so,
Yeah. But that's an important thing. You've got to get, you get that message out and let people know, because, here's the thing. You hear things like you just said from National or wherever that was from, you hear those things. We have to have something out there. We have to have stuff out there to refute that, to let people know that there is something very powerful about the work we're doing. This is not something we're just entertaining ourselves about. We've got a very powerful tool in restoring health and to humankind, and people need this. And so to me, it's not just about us and putting this badge on top of ourselves and saying, look at us, look at us. But I think of it like, look at what we're doing here. Humanity needs to look and see what we're doing here, because it's benefit to everybody. Anybody that's subluxated is going to be much better off, and in many times going to restore different issues that's going on if they'll address that. So people have to know this. So they have to know it in the marketplace, but you know what? We also have to. It has to be known in the medical literature. That sounds like a bad word, but it just is what it is. So.
No, it doesn't sound like a bad word. I completely agree.
Right.
So I completely agree, because the
Right.
thing is that we have to stake our claim and say, this is what we do. This is what we don't do. This is what we do. This is our results, and stand on that. And like Sigafoos says, right? Like anything that you're doing besides addressing subluxation is about thinking you're more or thinking that you're more than what you are, in chiropractic is less than what it is. Like, this is chiropractic, and that's what's important.
Well, it's interesting. Sigafoos was actually one of my early mentors as well. Dr. Kale was my mentor in early upper cervical, but Sigafoos was the one that I started following him around, and he's the one that really lit something in me, and lit a flame that really gave me a purpose. And it was already there; it just kind of watered it, and gave me a drive. And for whatever reason, my path went down this direction. I just had it just became, doing chiropractic, I just became very thirsty for knowledge, information, understanding, and so on and so forth. So, but Sigafoos, you brought him up, and I have a lot of fond memories from him. So yes.
That's awesome. That's awesome. So you're teaching for knee chest, right? Or you're teaching, you're publishing research. You've got a radio show after this, so I'm watching the time to make sure we're good on time there. Right. I know you mentioned Sigafoos. I know you mentioned your thirst. People need to know. It seems as though you're really outputting a lot, right? You're really doing a ton. You're flying all over the place. How and why are you nonstop like this?
Well, actually, in my practice, the way I have it set up, I see patients, and it sounds kind of funny. I see patients about 20 hours a week. And it's not because I don't love seeing patients. I love seeing patients, but the other responsibilities I have kind of crowd those hours in. I still see a full load when I see 20 hours a week, but yeah, you have to have time for that. And I have I have a wife and family, a 9, 7, and a 5 and a 4-year-old, and I love spending time with them. So you have to just balance those things out. But here again, here's the thing. When you're passionate about something, you've got this fire inside of you to do it. You are compelled. It's not like, I don't get up like you're referring. We taught this weekend at the upper cervical diplomate, the upper cervical neurology class. And I love those folks up there. They're very passionate. It's great. But I didn't wake up on Thursday and say, oh man, I got to go to Chicago and teach this weekend. It's like, it's something that feeds me, and I think that everybody can say it. Like, if you're in practice right now and you're seeing patients, you probably will find, if you have a great day or even a mediocre day, you have more energy at the end of the day than you do in the beginning of the day. I don't know if people can relate to that, but I always can. If I have a great day in the office, I'm jazzed up. So, to me, I don't look at it as a tremendous workload. I just look at it as, I'm just doing what I'm doing. I'm just doing what I feel compelled to do. moving forward that way. And I think everybody's kind of wired that way. Everybody has to find their purpose. If you don't find your purpose, life would be difficult, so when you get on your purpose and you get on your passion, then you just start serving that out, and it's not work at all. It's just, you're just doing what you do. So I like what Louis Armstrong says, do what you do and let the good times roll, so.
And I think a huge part of it, because we do have students who listen to this and really young doctors as well, is when we go into the analysis and everything like that, like when you go and when you adjust somebody, at this point in your career, there's no guessing, right? Like, you know what I'm going to do. I know what the outcomes are going to be. And if that's not something, or if that's something that bothers you or you leave and you're scratching your head at the end of the day, then maybe that's why you don't think chiropractic gets these results, because you're not actually addressing a subluxation.
Yes. Well, you know what, I could put some information on that. When I first got out in chiropractic, graduated at Logan, and for the first year and a half, I was just kind of doing what I was taught to do. And then I got around Sigafus, and it really changed, opened something up in me. I started really looking into chiropractic. That's where I found, the green books and BJ Palmer, and then I found Kale, and so on, so down the road. But I used to see it this way, that whenever I started in my upper cervical technique, I had a very clear-cut way. Now, it was all philosophically based, but it was also technically sound, that I knew I do this, 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 and then I can measure, like with my pattern analysis. Is the person clear? Are they not clear? I had ways of measuring my outcomes. And to me, just like what you said, it gave me confidence. And so I would always do this. And I've taught for a long time, and I always teach students this. I say, when you go up to the adjustment, before you make the adjustment, you want to make sure, at least in your mind, that you've done your x-ray analysis. You want to make sure in your mind that you're at least 100% convinced that you're right. Now, I'm leaving out, you might not be right, but you need to be 100% that whenever I stand over this table and do this adjustment, that I am right. Because when you have that confidence, it will help your adjustment. You can be exactly right and not feel like you're really right. And there's a lot of nuances that can go on when we do these adjustments. We're humans. There's different things that can happen between me and the patient when we're adjusting. And I got my mindset going the wrong way because I'm a little bit insecure about the listing or whatever. So that's one thing I always drill into students. Make sure that you're 100% confident before you step over that table, that you know that listing. And, at least do your best to convince yourself of that.
Yeah. And then post-check, right?
Post-check. And that gives you great feedback. That's one of the things I do, is I teach upper cervical neurology. And really the whole thing I teach in neurology is I teach people that, especially in upper cervical, there's 3 windows that upper cervical really reaches into the physiology of the body and the brain. We reach in by the autonomic nervous system. That's the reason why we did the pulse pressure study, to study that. We reach in through the cranial nerves, and we reach in through brain function itself. So you'll find in the literature, you'll find in JUCCR, which is Journal of Upper Cervical Chiropractic Research, you'll find multitudes of case studies based upon those 3 aspects. You'll see brain-based stuff get better. You'll see cranial nerve stuff get better. You'll see autonomic nervous system getting better. You see that reported over and over. And as you said in the beginning, these are case studies. But when you get a volume of case studies, it really is speaking volumes. We're seeing more and more. So when we do our upper cervical neurology, when we do our exam, we do exams based upon very brief exam. I can do a 10-minute exam showing me what the autonomic nervous system's doing, what the cranial nerves are doing, and what the brain's doing. And then I can come back after I've done my care, 6 weeks, 12 weeks, and I can recheck, and I can see, wow, my care really had an impact on the brain, or my care really had an impact on the body, because I can see it through these measurements. So in post-checking, like with your pattern analysis and all that, absolutely key. Absolutely key.
Absolutely. Well, I know you got this radio show to run too. I want to thank you so much. I got a ton of value. If you saw me looking down at all, it's because I'm taking notes. I was taking notes the whole time. So that was awesome. Just real quick, parting words of wisdom. If somebody wants to contact you or reach out to you, how they could best find you, and then I'll let you be on your way.
Okay. The best way to find me is my email, which is drk at drkessinger.com. So DRK at drkessinger.com. Just give me an email if you have questions or have any thoughts. I did want to say one more thing. We've got another study that we're just about to submit, and I'm very excited about it. It's on depression. And we found some really cool things, and we found some very good, strong, statistical, significant results in improvements in depression. We have 104 cases. We have here again, we had the 5 clinics doing this. And so it's going to be another case series with multiple clinics. We're getting ready to submit. When you submit, it takes a little while. It's usually about, if it gets published, you're usually about a year out. So hopefully next June, we can sit down and do
We can
this.
sit down again. If you don't mind me asking, what was your outcome measure? Was it Beck Depression Inventory, or what did you use?
We actually used the Goldberg Depression Scale. We did this because the Goldberg Depression Scale has been shown in the literature to delineate between symptoms of depression and anxiety. And why that's important is because when you study depression, somebody can have depression, but the findings can be clouded when they have anxiety with it. 30% of people with depression have anxiety, so you can get some variable in there. And not to let too much of it out because we're just putting it out there, but we found a high correlation with right atlas laterality and depression. Both before the patients came in, they reported higher, almost twice as much as depression, and they responded twice as well with right atlas laterality. Now that's not the secret. This is not a treatment. This is an analysis, and it makes sense because your left frontal lobe, that's where you get what's called your approach side, and your right frontal lobe, that's where you get your withdrawal side. And when the left prefrontal cortex, when it is weak, then it cannot stop a lot of withdrawal, negative behavior. And one of the things you'll get from that is depression, the right atlas laterality. When we adjust the right atlas, we know we get global effects from the brain with that, but we also get a very powerful impact from the right atlas to that left pole in the frontal lobe. So we saw a lot of correlation there, and that's the reason why we used the Goldberg, because it helped us delineate between those two. But we're really excited about this one. We'll see how it comes out with the publication process.
That is awesome. I'm super excited. Well, thank you so much for being on here. Guys, if you're listening, one of the things that we did was we took this article and we put it into a patient education newsletter. We're going to hand it out in our office. If you wanted to check that out, you can go to cardiovascular.com. I'll actually send one over to you too.
Perfect. That's great.
Yeah, it's one of the things we do. So thank you guys so much for listening. There was another episode of the Chiropractic Research Breakdown in the books. Go slay some subluxations, and I love you all.